Okay, we now move on to our next presentation on pre-implantation and genetic diagnosis with polycystic kidney disease. Momentarily, I will be joined by Joy Pekar, who is the Hamilton chapter coordinator for the PKD Foundation of Canada. Joy, who holds a Bachelor of Science and Bachelor of Education, is trained as a science teacher. Early in her relationship, she learned that her partner and future husband had PKD. She learned what this meant for any future children she might have and what options existed if they were to build a family together. Quickly, Joy learned that putting science into action was not as easy as it sounds. Many people, and even some professionals, don't know all the options out there. Joy shares that her family has benefited from being involved with the PKD Foundation of Canada for many years. She has found value in connecting with others who have been affected and learning from their experiences and from the professionals that specialize in PKD. Joy and her husband have volunteered with the PKD FOC by acting as workshop and symposium speakers, as well as planning multiple fundraisers. She enjoys sharing her journey because she feels that knowledge is power, and that by sharing the different options that exist in a way that people can connect and understand, she hopes that people will feel empowered to make the choices that are right for them. So I'm very pleased to welcome Joy to the conversation today and look forward to hearing about the implantation and genetic diagnosis with PKD.
Hi there, and thanks for logging in. I'm Joy Pekar, and I'm so thrilled to be here speaking with you today as part of the first ever PKD Summit hosted by the PKD Foundation of Canada. I want to take a moment to thank the PKD Foundation of Canada for organizing this event and creating an opportunity for people from all over the world to log in and learn more about important things that impact their lives and their health. I'm speaking to you today not as a doctor, not as a genetic counselor, not as a scientist. I'm here speaking to you as myself. So that you know, my background is that I have an undergraduate in biology and that I have a teaching degree, which means I know a pretty decent amount of stuff about science and I do a pretty decent job at explaining it, but that does not in any way take the place of a doctor or a genetic counselor. So I'll do my best to share the information that I know, both from the things that I've learned and also from my lived experiences. And I will encourage you in many places to seek out your own medical team's advice on how those things apply directly to you and your family when you're making decisions. So our topic for today is to help those people who are thinking about family planning and how it might be affected by their polycystic kidney disease to better understand what the options are that are available to them. We come from a history where there really were not a lot of choices. A few generations ago, we didn't understand that PKD was genetic. We didn't understand what genetic meant. We understood that it ran in families, but had no idea what to do about that. Science has come tremendously far, not only in our understanding of genetics, but also in the options that are available to families. And so my goal for today is to share those options with you so that you and your family can understand what those choices are, and you and your family can work together to make the decisions that are right for you. Every family is going to have their own process and their own journey. And to me, the biggest thing for me is that people have a right to know what the choices are and make decisions that are right for them. Nobody else can make those for you. So there will be no judgment passed here at all, just information and opportunities to consider your own path. And I will share with you certain pieces of my path as well. My journey starts here about 20 years ago when I met this guy named Gary. We met at a party and really hit it off. We got to know each other really well, really quickly. After a few days, my mother gave me a call and said, "Where have you been? I haven't heard from you. You're never home when I call you. Why are you so busy all of a sudden?" And so I had to tell her that I had met somebody. And like many mothers, whenever she found out I met somebody, came the list of interrogation questions. So she started to ask who he was and what he did, and asked about his parents and what they were like. And so I shared with her all of those things and shared with her that Ari's mother had kidney disease and that she was on dialysis at the time. Now, when he told me that his mom had kidney disease and was on dialysis, I was certainly sad to hear that she was going through that, but didn't really think about the implications of what that might mean. But my mother had one thing on the mind. She wanted to know where my future was going and if I was going to give her some grandbabies. And so that was the first question she asked when she heard about Ari's mom and her kidney disease. She asked if it was genetic. I didn't know what to tell her. I didn't know the type of kidney disease that she had and had no idea if it was genetic. But it was an interesting question, not one that really mattered. After all, we were just getting to know each other. But still, I asked Ari the next time we spoke, and he said, yeah, it was in fact genetic. It was called polycystic kidney disease, or PKD, and he shared that he had it as well. At the time, his kidney function was great. He was young and healthy and active, and his doctors were telling him that he had a very different future to look forward to than the one that his mother had, because science was coming along in a very different way. So really, it wasn't something that I worried about at all at the time. I did go home and Google it because, Google was around back then and I was the kind of person I was. I did find out very quickly that PKD is a dominant genetic disorder, and because of the background I had in science, I knew that meant that each of his kids would have a 50-50 chance of inheriting it. I also knew that there was this thing called PGD, which I'll tell you about in a little while, that potentially he could do that would prevent his kids from getting it. I learned about it in school. The prof made it sound like it was no big deal, just, one of those scientific things that you can do, and so his kids wouldn't have it. So with all those things kind of tucked away in the back of my head, saying, all right, so this is something that's kind of in his future. I don't know if that's going to be our future. It's there's lots of options, and it's just not something that I'm going to place a lot of stock in the decision at this stage because we're just getting to know each other. Fast forward a year and a half later, and we were very much in love, and he asked me to marry him, and PKD again was not part of that decision-making factor. I knew we had options. I knew I loved him and wanted to spend my life with him, and so we got married. So before I continue telling you more about my journey and where that went, I'm going to backtrack a little bit and tell you a little bit about genetics. I know that there's a large variety of people here, and that some of you may be extremely comfortable with your understanding of genetics, and some of you may feel very uncomfortable or not know much about genetics at all. So I'm going to do my very best to explain genetics in a way that might be new for some and might be very familiar or a nice refresher for others. I hope you find it helpful and meaningful. When I explain genetics, I use an analogy of a really, really humongous recipe encyclopedia. And so all that we talk about in the next few slides, it's going to be about DNA, but I'm going to explain it in terms of a really, really big encyclopedia of recipes. All right. Inside your body, there are many, 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 many cells. And inside every one of those cells, or almost everyone, there's always an exception in science, there is a nucleus. The nucleus is the library that houses the encyclopedia. Inside your cells are chromosomes. The chromosomes are the encyclopedia books. The DNA is the writing inside those books. And you see those letters, the A, T, G, and C? Those are the literal letters inside the books. Every single one of these recipes inside this humongous cookbook has many, many, many steps to create the machinery in our cells. So when that machinery is made, it's called proteins, and proteins do the work of the cells. It may be a crude analogy, but it's going to be extremely helpful when we think about how this all works. Let's break it down a little bit. You have 23 different kinds of cookbooks, or 23 different chromosomes in your body. You have 2 copies of every cookbook because these recipes are so vitally important. They're literally the recipes that make you. They make your hair color, they make your eye color, they make the shape of your kidney, they make the shape of your heart, they make every single aspect of your physical body is described in these cookbooks. So like I said, we have 2 copies of each one because each of these things is so vitally important. You get 1 copy of your recipe book, of each recipe book from your mom, 1 copy of each recipe book from your dad. And all of those recipe books are pretty well the same. So you have 2 copies of your mashed potato recipe. You have 2 copies of your hot dog recipe. You have 2 copies of your famous burgers recipe. You have 2 copies of every single recipe. Now let's really focus on this recipe analogy for a minute. You're having a family barbecue and every single recipe is really important. Your barbecue must have mashed potatoes, must have meat, must have asparagus, must have salad. Every single recipe is important for your barbecue to go well. I would argue the same is true in our body. Every single gene in our body, every single piece of information in our DNA is important for our bodies to be healthy. Now, I want to take a little minute to talk about mutations. Mutations are getting a lot of attention right now, and people really think about them as bad. And I actually want to share with you that mutations are not bad. Mutations are just different. So when your parents are photocopying their cookbooks, because this is a thing that cells do, they make copies of their DNA in preparation to give them to their offspring. So when your parents are making photocopies to their cookbook, or when your DNA is being replicated, then the photocopier is not a perfect photocopier. Sometimes it's going to make mistakes. You would think that's a bad thing, but honestly, it's an important thing. It is one of the most important things that makes evolution work, because if the photocopiers worked perfectly every time, then all we could ever be was just as good as what came before us. But if there are changes every now and then, some of those changes will not be good. Some of those changes will lead to things like PKD or Huntington's disease or muscular dystrophy or breast cancer, but some of those changes will be good, will lead to people who are faster, stronger, more intelligent, more creative, and that is what creates diversity and strength, not just for people, but for every single living thing out there. The way we create diversity, it's not something that we create. The way diversity happens is, and the way adaptations happen, is that there is variety. And the way to get variety is to have a photocopier that's imperfect so that new characteristics can emerge. All right, so that's my little bit about mutations. Phew, thanks for listening about that. I hope it clarifies some things about mutations in general, helps us understand where PKD mutations have come from, all kinds of other genetic diseases mutations have come from, but also helps us to understand that mutations are not necessarily a bad thing. They can be a good thing too, but it's the reason we have so many variants out in the world. Your cookbook gets photocopied from generation to generation to generation. In other words, your DNA gets inherited from generation to generation to generation. Sometimes that photocopier is broken, and so the next generation will have a typo in their cookbook. Now, once that typo is in that cookbook, it doesn't go away. So when it gets photocopied for the following generation, that mutation, that error, that typo in that cookbook goes from one generation to the next, to the next, to the next. So some of you out there may be in a situation where you've inherited your PKD mutation from a parent, and others of you might be in a situation where you're the first person in your family who has that mutation. So in your case, it was the photocopier that made the mistake for the first time in you. Either way, once that mutation is part of your body, it is part of your body. Once it's in your cookbook, it is in your cookbook. So what does that mean? What does it do? I'm telling you, you have these recipes. I'm telling you, you photocopy the recipes from one generation to the next. But what does it mean when you're cooking? But now we've spoken quite a lot about kind of what DNA is, what it does in our body. It stores all this information. It gets photocopied. It gets handed on from generation to generation. And it's not very likely to be perfect. It's likely to have imperfections because imperfections lead to diversity, and sometimes that's good, and sometimes that is problematic. And when we know about things that run in our family, when we know that those things are genetic, then we may be in a position to consider those things when we begin planning our families. So that brings us to the introduction or the topic of working with a genetic counselor. I know that people are in lots of different parts of the world watching this presentation, and the role of a genetic counselor may or may not exist where you are, or the role might be slightly different where you are. Here in Ontario, Canada, it is the job of a genetic counselor to help you understand when you have a genetic condition in your family, what that means for your family planning. So pretty much exactly what we're doing here today. A good genetic counselor will always start by learning your family history, not just related to PKD, but related to everything. Especially if you have a single gene disorder. I say single gene disorders because some genetic disorders come from other things, but in PKD and many other disorders like Huntington's disease or cystic fibrosis or muscular dystrophy, there's one gene, there's one recipe that has a typo that leads to that disorder. So that's called a single gene disorder. So in cases where you have a single gene disorder that runs in your family, they would explain to you, just like I did, probably without the barbecue encyclopedia analogy, that that you might be a carrier for a disorder, or you might have the gene and you might be affected by the disorder, and that maybe you have a 50% chance of passing that disorder on, or in the case where you're both carriers, maybe you have a 25% chance of passing that disorder onto that child. If you are pregnant, they can counsel you on your different options around pregnancy. If you chose to test the genetics of the baby you were carrying, that is something they could help you with. If you were hoping to better understand your genetics, they could help you do genetic testing for yourself to find the specific mutation that you carry. We even had a situation when my husband is also a transplant recipient, and so somebody wanted to be tested and also wanted to find out if they themselves had the genetic disorder, so they were able to get their genetics tested for that reason. So genetic counselors can help you understand genetic implications in a lot of different ways. So when my husband and I first got married, we knew we didn't want to start a family right away, but we knew that we were hoping to do PGD in planning our family, and we knew that working with a genetic counselor would be a valuable step in that. So it was pretty early on in our marriage where we sought genetic counseling. Our genetic counselor was lovely, and she did talk to us about the different options. She explained the inheritance pattern. She explained that each of Ari's kids would have a 50-50 chance of inheriting PKD from him. I already knew all of that, but that's okay because she was doing her job, and that's fine. She also explained other options such as adoption, such as using donor gametes, such as prenatal testing, that if we were to get pregnant without any intervention, they could requisition testing very quickly that would usually be by amniocentesis, and test the genetics of the baby, and that we would have a choice on whether or not we wish to continue the path of the pregnancy with that child if they tested positive for PKD. And then she said the meeting was over. Do you understand all of your options? Yes, that's great. Thank you very much and have a nice day. And I said, well, wait a minute. What about PGD? And she said, PGD, how do you know what that is? And I'm like, well, because I have this undergraduate degree and my professor talked about it. And he made it sound pretty straightforward. And she said, well, it's really new. And I said, really? Because he made it sound like it started in the 80s, which it did, by the way. She said, yeah, but nobody's using it. And I said, really? Well, I think we might want to use it. Can you tell us more? And she said, well, it's really expensive. And I said, okay, we just got married. We want to save up some money. This is something we'd like to learn more about. She said, well, okay, if you really want to learn about it. And then she sat down and explained it. And the truth is she didn't know very much because at the time it was very new to her. She hadn't had a single family go through it yet. And I would argue she didn't explain it to any families. So how many families might have considered it if they knew it was an option? But if she's the one who's meant to empower people with information, and at that time, she wasn't empowering people with information that this exists. She was biased because she felt it was too invasive. She was biased because she felt it was too expensive. And it is invasive and it is expensive, but it's also everybody's personal choice into what is too invasive and too expensive for them. I will say that Ontario, since that time, there has been some coverage through the government to support people who are getting pregnant through these means. That's obviously very different depending on where you are in the world, so I won't comment on that too much. One, because I'm not familiar with that process here, and two, because that process in terms of financial assistance and coverage does vary greatly from region to region, but it might exist. So I guess my 2 cents on a genetic counselor is that it is a valuable tool. It's a valuable conversation to have, but just as any other person or any other professional, they're not perfect and they may come to the table with their own biases. In the end, we were able to help our genetic counselor see that people are interested in learning more about this and may be interested in doing it. I will say that, actually, I'll continue to the next slide and jump back to that later. So the title of this presentation has PGD in it, and I've just started talking about PGD, and I haven't actually explained what it is. So here I am, I'm going to explain it so that you know. One of the options around how you can choose to have a baby is you can create an embryo using IVF, which means that you work with a fertility specialist to extract eggs from a woman's ovaries and to extract sperm, put them together to make embryos, and then you can test those embryos. They grow, and this is normally what's normally part of IVF is that they take an egg and a sperm and they put them together and they watch them grow, and if they're growing well, then they transfer them back into a uterus where they can hopefully grow to be a beautiful, healthy baby. They can grow from anywhere between 3 and 5 days outside of the uterus while the fertility specialists are monitoring their growth. And when they are 3 days after they've been inseminated or after they've been created, then you could potentially test that embryo to see if it has the same genetic information or the genetic mutation of the parent who is affected. What that means is instead of testing the genetics of an adult, or instead of testing the genetics of a baby that's growing in a uterus, doctors are able to test the genetics of an embryo before it's in a uterus, before it grows. And they can make the choice to transfer only healthy embryos, only embryos that do not carry that particular genetic mutation into a uterus to create hopefully a healthy baby. So that's a very broad introduction on pre-implantation genetic diagnosis, or PGD. And it very literally is that. Before an embryo is implanted into a uterus, so pre-implantation, we're going to diagnose its genetics. We're going to understand if that embryo has the mutation that leads to PKD in people. Now, like I said, at the time that we were having this conversation with our genetic counselor, it was not that new as far as science was concerned, but it was also not mainstream and common. I will say that in preparation for this talk today, I did go and review some of the recent research, and I can say that there have been thousands of babies born through PGD, and that it's not just for PKD, but that it is hundreds, literally hundreds of single gene mutations that can be detected using PGD, and thousands of healthy babies have been born, preventing passing on of those genes to those kids. And okay, so how do they actually do it? This is actually part of IVF. It's not specific to PGD. The medical term for it is ovulation induction and egg retrieval. And what that means is, in a normal cycle, a woman's body prepares to release 1 or possibly 2 eggs from the ovaries into the uterus, where they can be fertilized by sperm. Ovulation induction involves using some strong hormonal medications to prepare the ovaries to release multiple eggs, or prepare to mature multiple eggs. And instead of those eggs then being released into the fallopian tube and the uterus, there's a medical procedure where the eggs are removed directly from the ovaries into the medical equipment. I'm not going to give the details of that, but they take it directly out of the ovaries, out of a woman's body, so that the doctors can then continue the IVF process in the lab. The picture of an egg carton might be a little bit facetious, or a little bit of a tad of humor, but on the flip side, I like using an egg carton because an egg carton's an even dozen, and a dozen is actually a really good number of eggs to aspire to in an IVF retrieval. If you don't have enough eggs retrieved, if you have a very small number of eggs retrieved, the odds of you having a successful cycle become much lower, and I'll explain a little bit more about that as we move through the stages. And then if you have too many eggs retrieved, or too many eggs that mature, then you can have a very serious complication called hyperstimulation syndrome. I don't remember exactly, but anyways, you can hyperstimulate the eggs, and having too many is also a bad thing. So a dozen is actually a pretty good number, and you would hope to get somewhere around there if you were going to be doing IVF or IVF and PGD. So the first step, getting a bunch of eggs. Next step is fertilizing those eggs. And you can see there are 2 different versions of how IVF can be done in terms of fertilization. Option 1 on the left is they mix an egg with a whole bunch of sperm, and one of the sperm go in and fertilize the egg. That's option 1. Option 2 is using a technique called ICSI, intracytoplasmic sperm injection, where they take just one tiny sperm and they inject it directly into the egg. If you're doing PGD, you will always be doing ICSI to fertilize the eggs. The reason for doing that is because every single one of those sperm has genetic information in it. In my case, it's my husband who has PKD, and so some of those other sperm are going to have the PKD gene in it. Once we get to a point where in the lab they're taking one of those cells to test the genetics of that one cell, if they accidentally get some of the genetics of leftover sperm that are hanging around the outside, that could lead to a false error, right? Because how do we know if they're looking at the genetics of the embryo or looking at the genetics of a sperm that didn't fertilize the egg? So to just have a very clean fertilization with no risk of having misinformation, then they just inject one sperm into each egg. they wait for 3 days for that beautiful little fertilized egg to grow and grow and grow, and then it becomes what's called a blastomere, and one single cell is removed from the blastomere. Take comfort in knowing that there is no harm done to an embryo when one cell is removed at this stage. And through the magic of science, they can actually analyze the DNA of that one little cell and tell us if that one cell has the mutation that we are looking for and worried about. And so remember when I talked to you that a dozen was a really good number to have? Well, think about it this way. Let's say you did really well and you were able to retrieve a dozen eggs. Of those dozen eggs, not all of them actually fertilized. So maybe 3/4 of them fertilized. Okay? So now you've got 9 fertilized eggs. And of those, not all of them grew because they don't all grow very well in the lab. So maybe you now have seven blastocysts that you are able to biopsy. And let's say of the 7 that you biopsy, 3 of them are affected and 1 of them was untestable. Sometimes that happens. And so you have 3 remaining embryos. And of the 3, you choose to transfer 1 or maybe 2 and freeze 1 or 2 for later. That is a really great scenario. And it's a very realistic scenario as well. I'm going to take a very small amount of time to talk about PKD and pregnancy. In our family, that was not a factor that was relevant in our decision because in our family, it's my husband who has PKD and not myself. But in the case where it's the person who would typically be carrying a pregnancy that is affected by PKD, then this is a time where you really need a multidisciplinary consideration to decide what's best for you and your family, because depending on the stage that you're at in your PKD, there may be implications to you and there may be implications to the baby as well. I did some preliminary research on this. I'm not going to get into a lot of details because I am not a specialist in this area by any means, but it appears that if pregnant person is on dialysis, then that is of particular high risk to both the baby and the mother. And that if somebody is post-transplant, then in some cases they may experience rejection, either during pregnancy or particularly after is a time that they're worried about. So if in your family, the person considering PKD, the person considering PGD and pregnancy happens to be a woman, then it is important to talk to a fertility specialist, a nephrologist, and an obstetrician when making your decisions that are right for you. I will say that there are cases where families chose to move forward with PGD in this case and chose to work with a gestational surrogate. So they were able in those cases to have the mother go through the ovulation induction and the egg retrieval in a way that was safe, and then through the gift of gestational surrogacy, that baby was carried to term by the surrogate. And so it was the genetic offspring of the intended parents, but there was a surrogate who carried the baby to term. So the miracle of science means there are many choices. Each jurisdiction has their own rules around these choices. Each jurisdiction has different pricing structure and coverage structure. They're big decisions, but the options exist from a scientific perspective, and I think that's helpful to know. And on that note, I will share briefly a little bit about our story and how we went in all of this. So we met in 2002, and we were very young at the time. We got married in 2005, and we said we want to enjoy our time as newlyweds. We know that having a baby will be a complicated process, and we're young, and there's so much world to see. So a lot of the steps that we took, we did very slowly intentionally, and some of the steps that we took more slowly, we did for stress reasons or whatever reasons. There were lots of reasons. It is not normal that it would take this amount of time. So in April 2006, we met the genetic counselor for the first time. In October 2006, Ari did his genetic testing around PKD, and they found that he in fact does have a stop cooking or stop codon instruction far too early in his PKD1 gene. In April 2007, his mother, Alana, did her genetic testing, and she had the same stop codon mutation in her PKD1 gene. So they could say very definitively, this is the mutation that caused PKD in his family. In March 2008, we chose a fertility clinic locally to work with, and fertility clinics are quick. So in April 2008, we began our fertility testing for both of us. In September 2008, we did our first IVF and PGD cycle. So we went through the process of doing all those hormone stimulations so that I could produce lots and lots of eggs. If you are going through this process, be very gentle with your partner who's being injected, because these medications are injections, and they are hormonal, and they are intense, and it is a very difficult time for everybody, but it is especially difficult for the person undergoing the induction. They did the egg retrieval, and I did not get 12 eggs. I got 4. Of the 4, 3 of them were able to be fertilized with Ari's sperm. Of the 3, only 2 grew, and of the 2, 1 had the gene for PKD and 1 did not. So we transferred the 1 embryo, and a couple weeks later, we went back for a blood test to check if that transfer created a pregnancy, and it did. And then a few weeks later, that pregnancy resulted in an early pregnancy loss. And of course, that was extremely devastating. We knew that that was a realistic possibility, but we were still completely in shock and denial that it was a realistic possibility that could happen to us. So I share this with you not because I want to discourage you, but because I want you to know that, this is what it looked like for us, and that for every family it's different. That was our first cycle. There were more after that. And many times, we had to have conversations with our doctor about what makes sense for a plan and what makes sense to try next and what doesn't make sense to try next. And we had to reevaluate the questions. What we thought we knew, what we thought we had decided, we had to go back and reevaluate several times. I'm not going to share any more of my story at this point, because there comes a point in my history where my story is no longer my story, but it's their story. And I am so astronomically grateful to have these 2 beautiful human beings in my life. I'm so privileged to be their mother. And I am really glad that I had the opportunities that I did to make the decisions that we did, to understand our options and make informed decisions every step of the way. So I appreciate your time. I appreciate your patience. I appreciate you hearing my passions, and I want to open the floor now for questions. I do feel that, you're welcome to ask or comment in any way that you'd like, and I will do my best to answer those. Please remember that I'm doing it from the lens not of a medical professional, but of a person who's been through this journey myself, and one that hopes to be able to help you in your journey as well. Thanks, and we'll move on to the Q&A segment.
Thank you, Joy. That was a very informative and personal journey that you shared with us on the options of IVF and PGD. I know, like you said, you're coming at it from your own personal lens, your family's personal lens, and that's all you can speak to. But there's so much value in that. And this is thankfully not been our first time going through this talk. You've shared this journey in one way or another a few times at our chapter meetings. And I think that that's a very valuable conversation to have in those small, intimate groups. Because for a lot of people in a forum like this, they may be a bit too shy, a bit too reserved to come out and ask those questions, but in a smaller room where they can kind of pull you aside and ask you private questions, it may be more suited for the topic. But I do have some questions that we'll run through and we'll see where they get us, if that's okay with you, Joy.
Absolutely.
A lot of this stems around the emotional and the mental aspect of making that decision and how your emotions ran through the journey. So can you start with telling us a bit about how you or how you and Ari prepared yourselves mentally and physically for this journey?
We did a pretty terrible job of that, to be honest.
Okay.
We're very logical, pragmatic people. And so we do a spectacular job getting information. I'm not the type of person to Google things. I'm the type of person to look things up in medical research literature because, you know, I've learned how to do that. And that's kind of where I get the bulk of my information. We knew it would be stressful, and so we wanted to be at a place in our marriage where we'd had an opportunity to have some fun and quality time together and do some nice trips, you know, see the world. So we knew we needed that piece to be ready, but we focused very much on the pragmatics and technicalities. And so when we experienced that first pregnancy loss, it was very, very difficult for both of us, just, you know, because logistically we knew that it could happen, but we were in no way emotionally prepared for it. And I don't think anybody can be emotionally prepared for that as much as they try.
So excluding the loss component of your first attempt, hindsight is a wonderful thing to have. Going back, what would you tell yourself and Ari? What would you change, or what would you do differently, if anything, or would you be the same?
I don't think I would necessarily do anything differently. I think connecting with people who have been there is invaluable, especially when your hormones are doing super intense things because of those medications. So we really benefited, or I in particular really benefited from some online forums for people who were going through those treatments at the same time. At the time, there were not a lot of people doing PGD on those forums, but there were some, and even just being online with people who cycle at the same time. And so, you know, we all did our pregnancy tests at the same time. We all did our retrievals at the same time. And I'm still friends with many of those women today. You know, our babies all got together, and you know, these are all the babies who met at the same time. So if anyone's looking for an online forum that is fantastic and confidential, ivf.ca is a really valuable one.
Great. So that leads into another question then that was asked about the different types of support groups that are out there. So you mentioned some on social media, so Facebook.
There are groups on Facebook, but of course Facebook isn't anonymous, right? You're going in with your own name, and I am a private person and definitely preferred the anonymity of being able to share very openly about what we were experiencing without having my name attached to that. You know, I created a screen name and that people knew me by that name.
And of course, the caveat of Facebook is that you have to be mindful of the type of information that you get there. It's not the same rate as going to an organization or a patient-driven foundation. And we see that in the PKD groups. You can get caught up in a lot of the static of social media groups of that nature. So it's good to have alternative supports in place. If not too personal to ask, did you ever consider speaking with a therapist about the processes and the emotions of loss and the journey that you and Ari went under? Was that something that would have been valuable had it been offered, or is that not your take on things? Can you speak to that?
At different stages of our journey, we certainly explored if that was something that was appropriate for us. And I know other people do that as well. If I did or didn't, I don't know that that's specifically relevant for this conversation, but I know that many people do benefit from that in their process, because it's a lot to think about. One of the challenges is, especially when you want to share the technicalities of what you're experiencing, you're probably going to be spending a full hour explaining what PKD is and what PGD is. And, there's a lot of science to unpack there. So if you are seeking a therapist, it might be valuable to seek a therapist who has experience in supporting people in an infertility journey, because at least somebody who has the infertility piece and knows IVF, it's a very small leap to understand from IVF to PGD.
Excellent insight. I'm glad you closed on that point. Someone asked about the biggest stigma surrounding PGD that you can speak to, like whether that's the biggest piece of misinformation or stigma. Like what if you wanted to clear the air and had the ability to do so for someone that was considering it but has those reservations, what would you tell them?
So two things I think that I would want to talk about. One is that there's a lot, or I would say initially when PGD came out, people don't really talk about it as much anymore, but initially when it was introduced, there was a lot of talk about designer babies. And it is a completely ludicrous thought that anybody could ever do PGD to create a baby who has a particular physical build or a particular physical characteristic or a certain type of creativity. Even if we knew all the genes for all those things, the statistics of every gene that you're testing cuts down the opportunity or the number of potential embryos that you'll be using at least in half, right? And so we were looking for one gene that we knew our family had a 50-50 chance of any child that we had inheriting. And we had one embryo to transfer. Well, and we did multiple cycles, and on no cycle would we ever in a situation when we had more than one embryo to transfer. So if I also wanted to choose, my child's gender, which is illegal, or their eye color, which is illegal, the laws are in place to prevent that. But even if I wanted to, you can't take one embryo and say, well, I'm not going to transfer that because it has the wrong eye color. You don't humanly make enough embryos for the concept of a designer baby to be remotely a thing that would exist.
So do you think from starting your journey to present day, that playing God or designer baby component, do you think that it has shifted more into the realistic approach? Like you've just been able to myth bust a great chunk of the ticker, the headlines that come to play of people opposed to this. So do you think, has there been a shift in the conversation, or is that hard to tell?
I think it's just not a mainstream conversation anymore. The media has just moved on to other things. And so in medical communities, where it's relevant, so, in the PKD Foundation, we're talking about it. In the Cystic Fibrosis Foundation, they're talking about it. In the foundations of those groups where it is relevant, people are having those conversations. The truth is that you are creating an embryo in a lab, and then you are making a decision about the fate of that embryo. And that is something that different people have different ethical opinions about. And it is not something that anybody has the right to tell you how to feel about. It is something that each individual person or partnership who is planning a baby needs to make a decision for themselves. about how they feel about that.
And you spoke to, so obviously it was different in your scenario because you aren't the one affected by PKD, so a nephrologist wasn't involved per se in your planning. For those in the reverse role and those that want to speak to their nephrologist, would you have a recommended maybe top 3 questions to ask the neph that may involve their kidneys or would put them in advance?
So I think a lot of that depends on what stage in your
Sure.
kidney disease you're at. Somebody who is, in the early stages of kidney disease, somebody maybe who's taking tolvaptan, somebody who is on dialysis, or someone who is post-transplant. I think those would be very different conversations at each of those points. I think the biggest questions are, how might a physical pregnancy impact me? How might a physical pregnancy impact my child? And if you were considering doing a surrogate, even something, because I don't know if there's specific research. I know there are cases and there have been published cases, but I don't know if there's research overall on the ovulation induction process at different stages of PKD. And I don't know if nephrologists will have a quick answer for that because it's not something they encounter very often.
That's right.
So I would, ask the questions, how might an ovulation induction impact me at my particular stage? But then give that nephrologist time to go and find an answer because they may not have an answer, or they may not have an answer right away.
And it's much like any chronic disease. It's working with your team, right? It's involving the fertility specialist. It's including your nephrologist, your social worker, and making sure that everybody knows what everyone else is doing for the best interest of that. Now, you've been kind enough when people have reached out in the past and had questions, again, that weren't comfortable asking in a public forum, we've been able to point people towards you by email. Is that something that, if there are any questions from those in attendance today, that we could connect them with you privately to address any questions that may not be suited for asking now?
Absolutely. I included my email on the slides for that reason. So if anybody would prefer to reach out in a private capacity, then I am comfortable with that. I will say I'm also in a number of Facebook groups related to PKD, and the topic of family planning does come up quite a bit, more often around pregnancy than around testing and PGD. So anytime the topic comes up, I say, here's this other thing that you can think about. If you'd like to know more, feel free to send a private message. And one thing that comes up fairly regularly that people don't realize or don't give consideration to is, can you make decisions around family planning if you are not at a stage where you yourself are ready to know your own status? And so I see this with a lot of older parents of adult children, and their adult children are not comfortable knowing if they have PKD or not, and they're not ready to be tested. It's a very theoretical thing. It has been done, but it's not super popular, and I'll explain why. But non-disclosure PGD means that somebody who has a family history of PKD doesn't want to know if they have PKD. They can go through the genetic testing and PGD process, and the doctors will treat them as if they have the mutation, and they may or may not have the mutation. And then the doctors will only transfer embryos that don't carry the genetic mutation. But I mean, if they didn't have PKD, then all of their embryos would not have the genetic mutation. It is not a very common procedure because it's invasive and expensive. And so some people say, well, if I'm really passionate about my children not having this disorder, but I'm not ready to learn myself, maybe I should just do the test so that I potentially save these funds if it turns out that I'm not carrying that mutation. But there are people who do choose to go that route. and the process would be exactly the same, and the doctor is sworn to confidentiality to not disclose your status to you. So it is an option that exists for some people.
That's very interesting. You spoke a moment ago about the conversation in Facebook groups and in meetings and that being more on the pregnancy side of things than the procedure side of things. And you always saying, well, you know, in case this is of interest of you or to you, or in case you don't know about this procedure, here it is, let me know. I think that's a very important piece of advocacy that you're doing, because for so many people, and you spoke of the specialists that you spoke to at the very beginning that didn't even present it as an option. If we're not given a full picture of what we're dealing with and how we can deal with it, it is a disservice. And I think that is the best word to use. So you never know who may be listening or looking for support or where their head's at. So when you're planting that little bit of knowledge out there that this exists, that you're there to talk to, I think is making more of a difference maybe than you even know for people out there, and to know that there are options and that there are people to talk to that they may not have any other way of connecting with. So I applaud you for being comfortable enough. And as we wrap this conversation up here today, I can't thank you enough for sharing your story. I mean, this is a very challenging conversation to have. I can't imagine the pressure of a question and answer period for that afterwards. So I applaud you for taking it with such grace, which I knew you would. That's obviously why you're here. But on behalf of myself, the foundation, and those in attendance, Joy, I really want to thank you for opening up and letting us know how you've been affected by PGD and the options that are out there.
Thank you so much, Jeff. Thank you for creating the opportunity. I really feel passionately that people need to know what their choices are, because you can't make decisions on what's right in your heart for your family if you don't know what exists. So thank you for creating that space for people to learn about that. And you know, if, like I said before, if people have questions, they are absolutely welcome to reach out. And
of course, you're the Hamilton Chapter PKD Foundation coordinator. So if there's anyone in the local area, they would see your face back when we're functioning as a proper society. They can get involved with you on a local level as well with your family.
Thank you.
All right. All the best, Joy. Take good care.